Great. So I'm going to present the results of what Simon would call a pseudo-academic study. Switch off. But it's our attempt to reflect and to document a project that, in a very kind of operationally very challenging context, and let alone being able to implement in this area, but then actually trying to do research is sort of a whole other question. So yeah, it's our attempt to sort of document and reflect on learning from northern Baragazal, and where in South Sudan we know that there's lots of conflict going on, but also they have these shocks and stresses of droughts and floods. We also have sort of underlying that these sort of systemic factors of poor market systems, poor government extension structures, poor social safety net structures, and as well as that, an environmental health context that is, like in Chad, is again providing its own risks to the nutritional status. Before we started, we looked at the coping strategies, and these are presented up there, and you can see that a huge proportion are skipping meals. They're not, I should probably use this. Yeah, skipping meals. They're not eating the entire day. They're borrowing food. They're gathering wild foods. They're eating this seed and stock. All of these different coping strategies have a massive impact on the nutritional status. And so that's why in PIN, we've in these contexts, we've seen resilience and nutrition security very much interlinked. And so the intervention, I should say that this intervention was implemented by people in need, but also for the first year with our partner, Alliance 2015 partner, CESV, and it was funded by the European Commission. It was implemented over September 2014 to November 2016, with the overall aim of improving the resilience and nutrition security of the target households. It had four main kind of intervention results that we aimed at. The first one is trying to address those systemic issues that I mentioned before, around the government officials, the community animal health workers, the agricultural extension workers and private sellers, so the markets, having sufficient capacity to be able to provide the services that were needed by the agri-pastoral households that we were targeting. The second was around improving production, both agricultural and livestock production, and when I say improving production, that's increasing, but also diversifying and looking at the processing and marketing of these crop and animal products, in order to also properly be able to address the hunger gap period. The third result is really aimed at sort of at kind of addressing this often false assumption that just increasing production is going to automatically lead to improved nutrition. Often we don't see that that's the case, so that's around improving the nutritional practices of the household, so making sure that the children under 2, that the pregnant lactating women all have improved diets, and at the same time looking at hygiene practices, as was mentioned in the Chad study. You might be eating lots of nice different types of nutritious food, but actually your body is not absorbing it because you're constantly at risk of various types of bacterial infection. So that the third result also kind of was looking at improving hygiene practices in the home. And the fourth was about, for the very poorest, most vulnerable households, increasing their assets. So the methods. It's what we call a controlled before and after studies. So that's where we have our target villages, but also found some comparison villages that had at the baseline quite similar characteristics. And then measured, sort of took a baseline and end line measurement through two primary means. The first was a MUAC survey, so that's a middle upper arm circumference survey of under 5 children to measure acute malnutrition. And the second was a household questionnaire, so that was looking at the knowledge, attitudes and practices across the different sectors of nutrition, food security, agriculture and WASH, to try and be able to give us some information on what was going on in the household that could explain any changes in the MUAC, in the acute malnutrition measurements. So there are results over just 2 years. On the left, we have where PIN implemented the project, and on the right, we're in the comparison group. And we did this sort of statistical test, and I'm not a statistician, so I'm not going to talk about that, but and we found that these results were sort of statistically significant. And as you can see, in the baseline, we're starting at 6.4% in the target group. That went down to 2%. In the control group, it started at 8.6% and went up to 21.3% in the end line, which is a sort of very worrying situation in the comparison group. So I'm going to skip over that because I don't have enough time. And so now I'm going to try and present some of the sort of underlying results. And what this slide is showing, this is from the household questionnaire, is the change in the dietary diversity of the different types of people in the household. So the under 6 to 23-month-old children, the 2 to 5-year-old children, and the pregnant and lactating women. And as you can see, we've got the sort of target group there in the middle and the control group on the right. And you can see a sort of a nice, it's not a sort of drastic increase, but a nice increase in dietary diversity across the board. But we're also seeing a small increase as well in the control group. Some of the activities that would lead to this change, we hope, would be was the kind of cooking demonstrations that were showing women and also men. So we had a kind of a 8-session plan with the different villages and tried to get the men engaged. So at least our target was at least sort of 3 out of those 8 sessions. We'd have someone from the household, some man come along as well from the household. And it was really important to sort of engage them in the nutritional issues and getting them talking to their wives about nutritional issues in the home. So on the left, you've got cooking demonstrations showing how to make diverse meals out of locally available crops and foods. On the right, we were distributing improved fishing nets, and we were measuring the kind of yields of fish, and saw that going up in the target villages. And obviously, having more fish in the diet is a good thing. So that was the dietary diversity. Here we're talking more about the frequency of feeding, and we saw quite a strong increase there as well. That was up 40% in the target group. And key activities, or like one of the activities that we're doing was supporting the community animal health workers to do vaccination campaigns and provide that service for the communities. So we've talked a bit about food going into the body, and now talking about the absorption of the nutrients. Diarrheal disease is one way of looking at that. We actually didn't find much of a difference. We actually saw a bit of an increase in diarrheal disease, and it was still actually very high. I think there's a slight issue with the measurement of that, in that it was percentage of children under 2 years. I think it would have been better to measure 8 months to 23 months. That would be more, we would have seen a more realistic picture. And I'm not really convinced that diarrheal disease is the only thing that we should be thinking about. There are lots of other things that could be influencing whether or not these nutrients are being absorbed, such as parasites, such as this enteric and environmental enteric dysfunction. This is basically just a kind of, it's quite a fancy word. It's where your gut intestine, a nice healthy gut, has villi, which is all kind of furry, and it slows down the food as it goes through, so it traps the nutrients. Whereas if you're constantly having some kind of infection, you might not have diarrheal disease, but this little bit of infection is wearing down the villi, so you have this flat intestinal wall, and the food just goes past, not trapping the nutrients at all. Those two, measuring parasites, measuring environmental enteric dysfunction, that requires measuring stool samples, as you were saying. That's expensive. That's very difficult to do, especially in a context like South Sudan. So we didn't manage to do it. Perhaps in the future we'll look at doing that. Where we did actually see, so we didn't see much of a change in diarrheal disease prevalence, but we did actually see a big change in treating children for diarrhea and providing proper treatment with oral rehydration salts. That went up by 28% compared to actually a reduction in the control group. and which means that if the children is being treated properly, the sort of nutritional impact of the diarrheal disease that they're having, and there's lots of diarrhea going on there, isn't so prolonged. So they're getting a proper treatment, even though they're having diarrhea, they're not going to have such a big impact on the nutrition status. And again, we saw a big increase in water treatment compared to the control group. Hand washing was measured through two different ways. First of all, through knowledge. I'm never really a big fan of these knowledge sort of questions, because everyone just repeats the same thing. Yes, we know to wash our hands after going to the toilet and before preparing food, and all this kind of thing. So we also measured percentage of households who had a hand washing facility, a designated space that was easy to use purely for hand washing with soap readily available in the home, as a hope that this would actually be more of a reflective indicator of actual hand washing practices. And this is where we saw a big increase from 1% in the baseline to over 52% in the end line, compared to just 4.7% in the control group. And sanitation, so that's latrines, we didn't see such a big increase. We saw a nice 9% increase, but control group 5% increase, so we're not really seeing much of a difference there. Just a couple of activities that we were doing. So hand washing facility demonstrations, how to make a tippy tap out of sort of vaguely locally available materials, and a jerry can, and as well as that milk processing, so to reduce kind of bacterial contamination of the milk that everyone is drinking all the time because they have lots of cattle. So that's kind of a quick run through of the results. Just a bit on the way forward. So as I mentioned, PIN has a global resilience building strategy. This sits alongside our nutrition security strategy. And it's how we've used it to identify some key investment priorities for the organization to build its own capacity in delivering its programming. As you could see in that sort of presentation, there were lots of different activities and lots of results going on, and it's actually very difficult to disaggregate the impact of each of the different interventions. And I think, to be honest, we need to be a bit, I think we just need to just kind of embrace the fact that resilience building requires a multi-sectoral approach, that you aren't going to be able to really disaggregate the impact of all these different activities in building resilience, unless you had a really complicated randomized control trial with lots of different arms going on, and that's for sure not possible in South Sudan. So what we're looking at doing as an organization is working more on the documentation of our programming. We've started some nice operational research partnerships with different research institutions, and where we're looking better to document our work, to help kind of contribute to global evidence, still with the idea that we need to be better picking out the interventions that are kind of most effective at building resilience. And so whilst we're kind of measuring the impact, I think one key area for us is also building the capacity to analyze the context before we start, so that this kind of analysis of different market systems, of socio-ecological systems, so that we can be able to better pick and streamline our activity interventions, that combination of the multi-sectoral intervention needed, which will then enable us to kind of be more efficient, be more cost effective, and then also be able to take resilience building to a larger scale. And that's all. Thanks a lot.